So under these headings, I'm going to discuss the neonatal pain topic. First, let's go to the introduction and history. So pain is a subjective experience which has two concepts. One is localized sensation. Second is a behavior component. And the word pain is derived from a Latin word which means poiene, and Greek word also poiene, which means penalty or punishment. Sometimes it is called as a fifth vital sign also. So coming to the standard definition of the pain, according to the International Association for the Study of the Pain, it is defined as an unpleasant sensory and emotional experience which is associated with an actual or potential tissue damage or described in terms of such damage. So coming to the basic history, in the 1800s, the morphine was isolated from the opium poppy, and from 60s to 70s, it was believed that infants have been believed that they are too immature, nervous system is too immature to feel pain. And adverse effects of anesthesia are also feared in units. In the 85, a landmark paper was published by Anand KJS describing various physiological effects, that is variations in heart rate and the fluctuations and saturations. So, describing these adverse effects of Liverpool methods. The Liverpool method is they used to do only pancuronium, giving pancuronium, no anesthesia for PDA ligation. So, challenging this Liverpool method, they have described some adverse physiological effects of Liverpool method, and it has shown and improved outcomes with use of anesthesia for the PDA ligation. It has shown that Liverpool method was not correct. And in 2003, it was a joint commission in the US. It has designed the pain assessment and management should be standardized in all the hospitalized patients, including neonates. So coming to 2004, the Neo Pain trial has come up with these outcomes. It's a neurological outcome and preemptive analgesia in neonates, which has concluded that the preemptive morphine infusion, which did not improve outcomes in ventilated neonates, both in term and preterm babies, and did not relieve the procedure pain also. In 2006, the cerebral cortical activation, it has demonstrated that following noxious stimuli in human infants, despite a lack of behavioral response for it. In 2010, oral sugary solutions given to the babies found that clinical parameters scores have been decreased, but results in no change in the cortical activation. And in 2015, European trial, it's a European pain audit in units where pain assessment and management was done in the European countries. Total 18 European countries have been participating in this trial. And coming to the next heading, anatomy and the physiology of the pain. So basic types of pain are two types. One is somatic pain and visceral pain. Somatic pain is of two types. One is superficial pain and deep pain. Superficial pain arises from the skin and mucosa, and it's usually carried by two axons. One is fast pain, it's carried by A delta fibers, and slow pain is carried by C fibers. So fast pain usually it's a large and myelinated. Conduction will be fast. It is a sharp and localized pain also. Slow pain is small and unmyelinated pain, and it is a diffuse and unpleasant pain. And whereas a deep pain arises from the muscles, tendons, and bones. Come to the basic differences between the fast pain and slow pain. Fast pain arises abruptly, whereas slow pain arises slowly after 1 second of fast pain. Fast pain is well localized, sharp pain, and slow pain is a dull pain. Fast pain is carried by A delta fibers, and slow pain is carried by C fibers. And fast pain relates to the somatosensory cortex areas and also cingulate areas also. Mainly cortex XS1, which is 3 to 1. Whereas slow pain, it projects into thalamus and very active with gray matter and some reticular formation of the midbrain, which also forms the center for pain perception. And this fast pain leads to the reflex withdrawal movement and increase in the sympathetic activity, heart rate, increase in the BP and respiratory rate, and the slow pain causes nausea and sweating, all these things. And as I mentioned before, fast pain arises from superficial structures, and deep pain, slow pain arises from the deep structures and muscle tendons and bones. So coming to the flowchart of pain pathway. Whenever there is stress, infection, or injury, there will be local release of chemical mediators like prostaglandin, histamine, potassium, bradykinin, substance P, all these things, and cause pain receptor stimulation, nociceptor stimulation. And this is the pathway for the pain, which carries A delta fibers and C fibers. When nociceptors are stimulated here by the chemical mediators, the stimulus will be carried from the A delta fibers and C fibers, and it relates into the first order neurons. These are the first order neurons, which are the dorsal nerve root ganglions. Both the axons of A delta and C fibers will relay in the dorsal nerve root ganglion. From here, it will goes to the dorsal horn or posterior horn of the spinal cord. Here, two nucleus will be there. One is marginal nucleus and also substantia gelatinosa. So, and their neurons will be there. It's a second order neurons. From here, crossover will takes place to the lateral white commissure of the spinal cord. Here, lateral spinal tract will goes. From here, it will goes to the brainstem reticular formation, midbrain projections, periaqueductal gray matter, and finally goes to thalamus, thalamocortical projections. Here, brain pathway has usually divided into two pathways. One is NST, neo-spinothalamic tract, and PST, paleo-spinothalamic tract. Neo-spinothalamic tract, which is connected by A delta fibers, and directly goes to the somatosensory cortex, SS1, SS2 areas, and also some cingulate areas which is present in the frontal lobe of the brain. We usually associate it with emotional component of the pain. And paleo-spinothalamic tract, which is carried with C fibers, that is low pain, and it goes to the thalamus and release in thalamus, hypothalamus, and some reticular formation, periaqueductal gray matter. These are the slides showing. And coming to the centers for pain perception, pain sensation, it may be subcortical centers and cortical centers are there. Subcortical centers, which are present in the midline and intralaminar nucleus of the thalamus and periaqueductal gray matter and reticular formation. And the cortical centers are three areas in the cortex: somatosensory cortex area 1, 2, and cingulate gyrus present the area 24. Next, SS1, which is present in the post-central gyrus, which areas 3, 1, and 2. And it's mainly concerned with the discrimination of the pain and interpretation of the pain. But SS2, which is present in the superior wall of the Sylvian fissure, which is just inferior to the posterior central gyrus, associated with the localization of pain and appreciation of the pain. And cingulate gyrus is area 24, which is present in the frontal lobe, associated with the emotional component of the pain sensation. And this is a schematic diagram of showing the pain pathway mechanism. So one is transduction. When there is an injury here, so local mediators will be releasing, and there the transduction process takes place. From here to the first order, second order neurons till spinal cord and brain, transmission process will takes place. And the pain pathways where enhancement of the pain and inhibition of the pain by the neurotransmitters is moderated in the spinal cord by modulation. And finally, pain perception or here takes place in the somatosensory cortex. And coming to the next component, assessment of the neonatal pain. So neonatal pain scales were there, more than 14 to 15 scales were there. In that 5 pain scales have been undergone rigorous psychometric testing. In that most important is PIPP score, which is premature infant pain profile, and which has been revised in 2014. Next is neonatal facial coding system. It's a neonatal pain and sedation scale. Next, behavior infant pain profile, and Towler-Ague Novi scale. It's called DAN scale, which includes which does not include any physiological parameters. It includes only behavior parameters like facial expression, activities of the leg, and vocal expression, like crying, all these things. So coming to the facial expression, common facial expression is neonatal pain is infant crying and brow bulge and eye squeeze and nasolabial furrow, which is deep, and taut tongue will be there, and horizontal mouth stretch. And coming to the neonatal pain scales individual description. Coming to the PIPP, which is most popularly known as premature infant pain profile. As a name implies premature, but this scale can be applied both in case of mature term babies and also preterm babies, which includes 7 components, 7 variables. That heart rate, saturation, facial expressions, behavior state, and gestation age have been included. Next, NIPS scale, that's neonatal infant pain scale, which includes facial expression, crying, breathing pattern, and arms and leg movements and state of arousal. Next is NFC, is also one of the early pain scales which has been used, which came before the PIPP scale. It's a neonatal facial coding system, which includes facial actions, like facial expressions only, which does not include physiological components. Next, NPAS scale, which is a neonatal pain, agitation, and sedation scale, which includes crying, irritability, behavior state, and facial expression, and also some vital signs. Next is cries, which is commonly used in some months children, like 2 to 3 months children. Cries is cry, requires oxygen, increased vital signs, and expression sleeplessness. Next, comfort scale, which also used in case of late-term babies and also infants. The calmness, movements, facial tension, and rate and blood pressure. Next DAN scale, which includes facial movements, vocal cord expression. Next is the FLAG scale, which is most commonly used in children. That is stands for face, leg, acuity, crying, and consolability. So coming to the main scale, that is PAPP scale, that is premature infant pain profile. Pain assessment is a key component of good pain management. So many pain systems were there, but only few have been validated. So most commonly used is PIPP scoring system. So it can be used for assessing pain in both term babies as well as preterm babies. So but it is not validated in case of ELGA babies before 28 weeks of gestation. There is a PIPP-R score which has been extensively studied in case of extremely low gestation age babies. It's validated in 2014. So coming to the indicators of PIPP score, which include 7 parameters: changes in heart rate and oxygen saturation, physiological parameters, and behavior parameters are facial expression like brow bulge, eye squeeze, nasolabial furrow, and these two are gestation stage and behavior state. So coming to the PAPP scale, which is most commonly used scale, as a review in 62 studies of PAPP score over 13 years reinforced the scoring system as a valid, reliable, and clinically feasible scoring system for measuring pain. And in 2014, almost 13 years, the researchers have found it's a refined scoring system, and it's a termed as PAPP-R score, is a revision score to better encompass the markers of pain across all gestation age. Here, coming back to the PAPP-R score. So unmanaged pain, which has some complications, some consequences will be there, like immediate consequences like alterations of hemodynamic stability and alterations stress hormone expression, and long-term changes like allodynia, hyperalgesia will be there, and some long-term neurological complications will also be there, like cognitive impairment and behavior problems like hyperactivity. All these things can be seen because of early pain in the neonatal life. And these are the PAPP-R score. So it also includes all of parameters, which includes changes in heart rate, which has 0, +1, +2, and +3. So the minimum score is 0 and maximum score is 21. And it has graded as score 1, score 2, and score 3. Score 1 is from 0 to 6, score 2 is 7 to 12, and score 3 is more than 12. And score 1, which includes minimal pain to no pain, and score 2 will be mild pain, and score 3 will be a moderate to severe pain. Next, the PAPP-R scale, which includes subtotal scores, that is how total score becomes subtotal scores, that is both behavior parameters and physiological parameters plus gestational score plus behavior score. Together comes total score. And if the subtotal score is above 0, add gestation age and behavior state. So the main comparison, why it was revised, comparison between the PAPP score and PAPP-R scoring system. In PAPP, there are decimal points are there. In both PAPP and PAPP-R score, total 7 components are there. In that, heart rate remains stable, and also gestation age also remains stable. Other parameters will change. Whereas oxygen saturation, it has been given from 0 to 2.4% decrease in the saturation. So we'll see the heart rate means increase in the heart rate, maximum heart rate we'll see, and saturation is the lowest level of oxygen saturation. So we'll see. So here the oxygen saturation 0 to 2.4% decrease. So this is decimal points. It's very difficult to evaluate in case of clinical scenario. So it has been rounded to the 2, 0 to 2 or below 3%, 2.5 to 4.5, 3 to 5%. So it's unable to determine the changes. So unable to determine the small changes in increments of decimals in clinical settings, and decimal points of oxygen saturation variables which have been rounded to the nearest whole number. Next, coming to the brow bulge, eye squeeze, and nasolabial furrows behavior parameters. Here it is seen in the percentage. That is in a 30 seconds block, in the video taping of 30 seconds, we will record post procedure 30 seconds, we'll see the pain, this is the pain. In the 30 seconds, this is a percentage. For example, 8% of the time baby is having pain. So it's an elaborate thing to evaluate. So it has been changed from percentage has been changed to the duration of time. Scoring was changed from the percentage to duration, which was observed in 30 seconds block. For example, 3 seconds, less than 3 seconds, 3 to 10, 11 to 20, and more than 20 seconds. And also baseline behavior state also has been changed, like active, awake, and facial movements. All these things are facial movements were there, more pronounced. But here, active and evacuation modes have been it has deleted. So instructions were made more specific and clarifications of definitions were made. Coming to the instructions, PIPP-R scoring instructions, there are 4 steps. First is we have to observe the infant for 15 seconds at rest and assess vital signs. That's highest heart rate recorded, lowest saturations. In 15 seconds, we'll see the heart rate and saturations and also behavior state, whether the baby is awake, quiet, or sleepy, all these things. Step 2, observe the infant for 30 seconds after the procedure and assess the vital signs. That's maximum heart rate recorded and lowest saturations and duration of facial actions which is observed in 30 seconds, like brow bulge, nasolabial fold, and eye squeeze. In infants requiring increase in oxygen, that means any point of time the baby requires oxygen, that is before the procedure or during the procedure. So they will receive the score of 3 plus 3 for the oxygen sat indicators. And step 3, score for corrected gestation age and behavior, which subtotal score is above 0. And step 4, we have to calculate the total score by adding subtotal score plus gestation age score. So difference. So coming back to the management of neonatal pain, 5-tier approach, which includes non-pharmacological therapies and also pharmacological therapies. This is a tiered approach. First, main thing we have to avoid the pain. The tier 1 approach includes non-pharmacological strategies will be there, like a non-native setting, all these things. And tier 2 to tier 5 will be the pharmacological approaches. Coming to the non-pharmacological therapies, that is sugary solutions. Oral sucrose or glucose, breastfeeding or bottle feeding. Next, skin-to-skin contact, KMC, swaddling, precipitated tucking, and NNS, and sensorial saturation. So all these are non-pharmacological therapies. This baby is getting oral sucrose solution. Oral sucrose, just proposed hypothesis that it is an endogenous opioid release, called as endogenous release of the opioids by unknown mechanism, and it decreases the pain and anxiety and stress in the babies. So most commonly 24% oral sucrose solution, 24% is commonly used. And systematic reviews by Stevens Bonu in 2004 has shown that has concluded that sucrose significantly reduces pain associated with the procedures. And meta-analysis showing that neonates receiving the sucrose are found to be significantly shown reduction in the behavior parameters as well as physiological parameters. The use of sucrose in neonates when compared to the breast milk and pacifiers can also be associated with reduction in the behavior indicators. Next, glucose. Usually we use 25% dextrose solution, and glucose also has similar also effective alternative to sucrose therapy. And some studies have shown that sucrose is far better than glucose, and some studies have shown that both are equally effective. And glucose is recommended for venipuncture and heel lancing procedures and decreases the pain scores, usually crying time in the neonates. And one systematic review done by Bonu demonstrated that there is no significant difference between the effectiveness of sucrose as compared to the glucose. And the recommended dose for sucrose is 24%, for glucose will be 30%. And care should be taken while using this sucrose in case of preterm babies to avoid the risk of NEC. We use high concentrations. Oral sucrose or glucose for analgesics is typically not effective after 3 months of age. Coming to the next topic, breastfeeding. Breastfeeding or breast milk. Shah et al. Demonstrated in coherent review has shown that the breastfeeding appears to have an advantage for one-time painful procedures. And also NNS also useful for only one-time procedures. Breastfeeding during the heel stick procedure reduces physiological parameters as compared to swaddling or pacifier use. And it has been demonstrated that the reduction in the PIPP scores, DAN scores, and NAPS scores and NAPS scores with breastfeeding just before the procedure, 2 minutes before the procedure. Next, a systematic review by Shah demonstrated that oral sucrose, and then it has been compared with the breast milk, showed reduction in the physiological parameters, reduced crying time, and lowest heart rate variability. And coming back to other non-pharmacological therapies like skin-to-skin contact, it also reduced the PIPP scores and neonatal facial cooling system scores also. And coming to the swaddling and facilitated tucking, which includes manual flexing of the neonate arms and legs, both foster self-soothing behaviors and are effective for reducing pain in neonates. And coming to the non-nutritive sucking, it has been reducing lower main heart rate because reducing the heart rate and also decreasing the crying time when compared to swaddling. It's a swaddling. It was comfortable. It's facilitated tucking. Coming back to the KMC and NNS, also useful in reducing the pain. Usually combination processes will be useful in reducing the pain. Coming to the sensorial saturation means so all the senses will be activated. For example, in this picture, the person is giving one sugary solution, sucrose or glucose to the baby. It is kept on the infant tongue and just doing some gentle massage to the baby. So one sugary solution means taste sensation, gustatory sensation will get activated, and this is a gentle touch sensation. And baby is looking at the mother side. Mother is speaking to the baby, and also visual sensation, and also when baby is talking to the mother is talking to the baby, auditory sensation also get activated. Also one of the proven thing in reducing the pain. So combination of non-pharmacological therapies provides synergistic effect. When oral sucrose or glucose is used in combination with NNS, reduces pain in units. So, as I mentioned before, sensorial saturation is a method of reducing pain in units. A multisensorial stimulation includes tactile, gustatory, and auditory and visual stimulation. Example, by placing this sugary solution in infant's tongue and then providing a gentle facial massage while speaking calmly to the infant. Next, coming to the topical anesthetics style 2. Usually we are using a eutectic mixture, EMLA cream, eutectic mixture of local anesthetics. It's a mixture of 2.5% lignocaine and 2.5% pilocaine, sometimes using 5% also. So this is a local anesthetic drug which can be useful because of venipuncture and circumcision, but it's not useful for heel stick. The pain reduction at the venipuncture in newborns and as an oral glucose compared to local anesthetics. So it is going to Maria Redding. It's a randomized controlled double-blinded study where 201 newborns undergone venipuncture. Here in this group, EMLA group, total 201, number 99. Here 102 people were there. So in EMLA group and glucose group, we are assessing the pain scale and duration of crying and heart rate variabilities. So the pain scores were after the venipuncture, we do the glucose solution 2 minutes before the venipuncture in this group. The PIPP-R score has been significantly lower. Lower scores were seen with a mean of 4.6 and compared to the mean of 5.7 in the EMLA group. And duration of crying was also low in case of glucose group, and with a median of 1 second and compared to 18 seconds in the EMLA group. And heart rate also, but heart rate there is no any significant difference. Both are similar in both groups. Conclusion. So glucose is ineffective in reducing the symptoms associated with venipuncture in newborns and seems to be better than local anesthetics and cream in EMLA. Coming to the type 3, that is acetaminophen, oral paracetamol, most commonly used paracetamol. They can be used oral or parenteral. So mostly it is used in the neonates, effective in the neonatal pain reduction. So recommended for mild to moderate pain, like heel sticks and adhesive tape removal and venipunctures. So recommended dose is 10 mg per kg per dose 6th hourly, or 15 mg per kg per dose every 8th hourly. Next is acetaminophen for the treatment of pain in neonates. It's a coherent review identified 8 studies evaluating the effectiveness of acetaminophen for the treatment of pain in 614 neonates. And neonates were undergone heel lance, oral acetaminophen 20 mg per kg did not significantly reduce the pain compared with sterile water. Oral glucose solution appears to be more effective than oral acetaminophen in reducing the pain scores. Coming to the type 4, there's a local anesthetics, that's injectable local anesthesia. Can be given for PICC lines, center lines, arterial stabs, central vein placement, and also from the. So this local anesthesia usually used for the brachial artery stabs and also peripheral artery incisions is most effectively used. It reduces pain and can be available as 0.5%, 1%, and also 2%. Can use a maximum up to 3 to 5 mg per kg. There is a risk for erythema and seizures. So pain management for neonatal circumcision. So if untreated pain is circumcision causes long-term neurological effects, mainly behavior problems will be there, like hyperactivity, all these things. So usually DPNB, dorsal pennine nerve block by 1% lignocaine given by shows in an RCT. Infants who are pre-medicated with lignocaine has shown smaller changes in the physiological and behavior parameters compared with infants who are not given analgesics. And systemic toxicity from injectable local anesthetics has not been reported. Coming to the deep sedation type 5, the most commonly used in our NHS opioids is morphine and fentanyl, commonly used, especially meant for the moderate to severe pain cases. For example, IN insertion, drainage, intubation, and chest tube placement, center lines, or when the baby is struggling on ventilation. So morphine in preterm units causes hypotension, bradycardia, all these things. But fentanyl provides rapid analgesia and has minimum hemodynamic effects, includes less hypotension, and it has less GI dysmotility and urinary retention when compared to the morphine. Bradycardia and chest volatility, well-known side effects. Coming to the morphine infusion, first the loading dose will be 10 micrograms per kg per dose, followed by infusion 40 micrograms per kg per hour. Fentanyl dose 1 to 3 micrograms per kg per dose. So naloxone can be for reversal of the opioid analgesia, especially for respiratory depression and all these things. So ketamine is not so much widely used here, and it provides amnesia, dissociative anesthesia, maintains respiratory drive, allows bronchodilation, which improves ventilation and hemodynamic function. Usual dose is 1 to 2 milligrams per kg per dose. Coming to the popular trial, Neopain trial. It's a Neopain trial. It's a neurological outcomes in preemptive analgesia in neonates. It's a randomized control trial in neonates to evaluate the poor neurological outcomes of ventilated preterm neonates with morphine infusion compared to placebo control group, where morphine infusion is given before any procedures did not alter the neurological outcomes of the preterm units. Rather, it did not decrease the pain also. So, coming to the fentanyl, it's opioid analgesia, 50 to 100 times more potent than morphine. It's a rapid onset of action. In a blinded RCT, a single dose of fentanyl given to the ventilated units significantly reduces the pain scores. So coming to the European trial, it's a European pain audit in the neonates. It has been done to audit the pain, assessing the pain and management of the pain, and uh, uh, how the healthcare providers are just assessing the pain in the 18 European countries. So just an audit in the European countries. Neonates who are in pain and stress during NICU stage receive some analgesia sedation. So investigate for current use of sedation and analgesia in NICUs in European countries. So 8 European countries have been studied. It's a prospective cohort study where 6,000 units were enrolled in 243 NICUs in 18 European countries. Showed wide variations in the sedation and analgesia practices. It has occurred between the NICUs and countries. It is varied. And the use of SHGs, that is opioids, sedatives, hypnotics, and gymnastics in intubated units might prolong their need for mechanical ventilation. And other sedatives like midazolam and dexmedetomidine, which are not popularly used, enough research has not been conducted. Dexmedetomidine, which is an selective alpha-2 agonist. The main advantage of this is when compared to morphine and fentanyl, these morphine and fentanyl have more respiratory depression. Dexmedetomidine don't have that much respiratory depression, won't be there. Coming to the next heading, that is long-term consequences of neonatal pain. So neonatal pain has some long-term consequences, like it affects on the neurosensory cognition. Cognitive impairments will be there, and behavioral outcomes, pain processing, and long-term health outcomes will also be there. Pain exposure, neurodevelopment outcomes, and poor cognitive outcomes in infancy. So extreme premature babies who require neonatal surgery was associated with increased neurosensory disabilities in the childhood and lower cognitive scores, low IQ scores that persisted into the late adolescence. It was due to the microbial proliferation. It is an injury causing the pain side and causing microbial stimulation, causes excitotoxicity, and this excitotoxicity causes the neuronal cell damage and decreases the volume of the brain. It was shown in the studies. And finally, causing low IQs, low cognition, and some behavior abnormalities. So following preterm births and NICUs, baseline thermostatic thresholds showed generalized reduction in the thermal sensitivity. So the prevalence of the recurrent pains, for example, chronic pains, which is popularly studied in the Norway, so Norwegian study, shows that there is increased risk for chronic pain syndromes like chronic fatigue syndromes in adolescents, and also some somatic symptoms can also be seen in the children. So coming to the next, long-term neurosensory and cognitive impairments. The study says that association between painful procedure in the early life and reduction in the brain response to non-noxious touch stimuli. And sensory motor impairment in children, such as impairment in visual, hearing loss, and impairment in touch in the childhood and adulthood, has been attributed to painful stimuli in the early life. And the neonatal surgery in the early life, which causes neurosensory disability, if not managed properly, it's effective pain measures, pain control measures, cause neurosensory disability which affects persisting to the adulthood at 8 years of age, with males having higher risk of disability, especially done with the circumcisions. And Early exposure to the painful procedures, it has a negative impact on brain growth, which is directly related to the cognition. There is an inverse correlation between the frequency of invasive procedures and amygdala and thalamus volumes for seen at 8 years old children born very preterm, associated with the lower IQ, language, and attention deficits, poor visual motor functions, and poor behavior outcomes. Coming to the behavioral problems. So early pain exposure in the neonatal period is not managed properly to be associated with attention deficit hyperactivity disorders and so hypervigilance and hyperactivity problems, anxiety startle response. And preterm babies who are exposed to neonatal pain have higher rates of atypical behaviors than full-term babies. It's coming to the pain processing, the presence of cortical activation, which is measured by the increase in hemodynamic response without facial motor changes, supports the concept that pain is a reflection of emotional response requiring cortical processing. So males with history of neonatal pain have more pronounced response than females with respect to the hemoglobin oxygen following secondary venous punctures. So only oxygen saturation variables are affected. And hypersensitivity and allodynia and hyperalgesias and all the abnormal pain perceptions are seen in children who are exposed to the early life pain. This last point, increased poor health outcomes. Early life pain, which is associated with greater risk for type 2 diabetes, obesity, hypertension. And finally, summary. So neonates who are experiencing pain, neonates also experience pain. Previously, it was thought that neonates, that nervous system was not so mature to pursue the pain sensation, but some studies have shown that cortical activation and all these things. So neonates also do they experience pain. It was studied, and the most common used pain score is PIPP-R scale. And the techniques such as group interventions and examinations by nursing care team, which is very much essential. And we have to avoid aggressive interventions like